This episode is brought to you by Abbott. In today's fast-paced world, health is often neglected. But this is a beginning to change as more people become mindful of their well-being. With chronic lifestyle conditions, especially cardiovascular disease, on the rise, this shift is crucial. How can we navigate this healthcare journey without disrupting our daily lives? How do we stay healthy and continue doing what we love without constant worry? When should we see a doctor? How do we recognize symptoms, adjust our lifestyle, and explore available technologies? In our hashtag Matters of the Heart series, we aim to answer these important questions. Breaking down CVDs, we are joined by Dr. Praveer Agarwal, an expert who will shed light on these topics for our listeners. Thank you, Dr. Praveer Agarwal, for being here. And let's dive deep into the discussions. Dr. Agarwal, can you help our listeners and viewers understand what are the different types of cardiovascular diseases in general and the emerging trends for coronary artery disease in particular?
See, cardiovascular disease is a group of disease that affect the heart as well as blood vessels. Broadly, if we can divide them, there are two groups. One is congenital heart disease and second is acquired heart disease. Obviously, here we are not discussing the congenital heart disease. We'll focus on acquired heart disease, which can be divided broadly again into three groups. One is ischemic heart disease, second is valvular heart disease, and third is a heart muscle disease called as cardiomyopathy. So in today's world, mainly we are discussing about the ischemic heart disease because there's a trend is there. This is on rise. So our more focus will be on ischemic heart disease, which is the disease affecting the heart vessels, causing less of the blood flow, leading to heart attacks and further on more problems. So we'll concentrate mainly on ischemic heart disease. And one more worry is there in the Asian subcontinent, the disease is coming quite early. Like in the West, the disease comes mainly in about, say, in the sixth decade, about maybe 60 years onwards. But our trend is that we are having disease more premature between 40 and 60. And majority of patients are presenting to us with an acute heart attack. Whenever you have a heart attack, you lose some heart muscle. How soon you get the treatment done, still you cannot have a normal heart once you have a heart attack. So our main worry is that presentation is acute attack, in which we know that few of them will not reach even hospital. So we have to identify this problem well before time, where we can really do a good role in preventing this disease rather than it's coming and treating after that.
Dr. Agarwal, angiography and angioplasty are commonly used terms, and we have heard this. So can you please explain us the procedure? And before explaining the procedure, can you just simply tell our listeners what is angiography and what is angioplasty, and what are the types and causes of blockages that lead to heart attack?
Right. So to answer the first question, what is angiography? Angiography is a diagnostic procedure in which we inject some dye into the coronary arteries and take a photograph from outside by an X-ray machine that tells about the abnormalities in the heart, especially in the vessels, especially the blockage in the heart arteries, as well as some other abnormalities like ectasias. So many things can be detected by angiography. Angioplasty is a procedure, is a treatment part. Like there's angiography is diagnostic part, angioplasty is the treatment part. Angioplasty started somewhere, I would say, in early 80s or maybe say late 70s. In angioplasty, what we do is we clear the blockage, right? Maintaining the blood flow to the arteries to the normal level. We started with a balloon only. It was a big breakthrough in, say, 1977 when the first angioplasty was done. So for about a decade or so, we had only balloon with us. So balloon was doing a good job, but it had not many complications. So in early 90s, we came up with the stents. That was a major breakthrough again when we knew that the results are predictable and there were more lesions we could treat. Then the era of stenting started, and then the new devices came in picture, like called as a miracle in the therapy was a drug-eluting stent. That came for the first time in 2001. And that was really a wonderful thing. Why? Because when we were putting the stents with the bare metal, the recurrence rates were very, very high, to the tune of about 30 to 40%. You treat now, and about 6 months' time, 30 to 40% will come back. And it figure came down to really less than 5% once the drug-eluting stents came in picture. Now in 2024, we are sitting into third generation of DES, which is much superior to even the first generation. And in between, an era came for stents which were disappearing stents called as bioresorbable scaffolds. But that era lasted, I think, only a couple of years. Still now we are getting back again to the stents which are disappearing, but still they are not in the commercial use at the moment. So presently, what we're saying, the stents are called as, in the common term, DES, that is drug-eluting stents, and they are producing good results and giving a long-term outcome to the patients. And your third question is, the blockages. You see, we have to understand the basic physiology. This blockage in the heart arteries is basically a process called as atherosclerosis. If we just see the anatomy, all the vessels, whether it's heart arteries or arteries other than heart, they have 3 layers on either side, and in between the blood flows. 3 layers means intima is the innermost, media and externa. With aging process, what happens is called atherosclerosis. These 2 layers internal, that is intima and media, they start getting thicker and thicker. And the metal deposit, that the fat cell deposits, cholesterol deposits, calcium deposits, they ultimately lead to blockages in the arteries, including heart. So this process is, if it is premature, that's the main worry. Mature disease is after 60 years of age, premature is before 60 years of age. And prematurity happens more in South Asia because we have got risk factors which are really, I would say, much more prevalent than anywhere else. And the risk factors are family history of heart disease, number 1, in young. Diabetes mellitus. You see, every other patient is looking like diabetic. My sugar is high. It's right now, I'm just avoiding all the eating pattern is changed, but still they are having genetic risk factors for diabetes, blood pressure high, and bad lifestyle, smoking, tobacco, but is prevalent very much. So these all factors lead to prematurity of the disease, which is really bothering us.
Doctor, you talked about disappearing stents that are not in commercial use anymore. We as listeners...
I'm not saying not anymore. They're still on trial. And there are the few brands are coming in, but still the data has to be produced.
But for a normal listener, we don't really have knowledge about how it works. Can you just elaborate them?
You see, the stents are of like, if you see the basic structure of a stent, there are 3 things. One is a metal. Over the metal is basically a slotted tube where the laser hole cuts are cut so that it makes flexible. And over that is a polymer. And on top of that, there's a drug which is absorbed into the polymer. So there are 3 components. One is metal, second is a polymer, and third is a drug. The drug gets released within, say, about 4 to 6 weeks' time. These drugs are anti-mitotic drugs. So they prevent blockage to come back. Second is a polymer. That also, the polymer has got 2 types. One is a disappearing polymer that disappears in 6 months' time, and one is a permanent polymer. And the third one is metal. That remains the whole life. So for the whole life. And what are the disappearing stents are that you take off this metal component and you make this polymer so thick, so this has strength. And then you put a medicine on that. So this is called a disappearing stent. Only thing is that deploying is very difficult because you can't see the stent. There's no metal there. It's all that you have to just visualize by imaging. Otherwise, you can't see the stent. So putting the stent is slightly more difficult than a routine one. But what the companies claim is that, look, this drug disappears in 6 to 8 weeks' times, but this polymer also goes from the body in about 3 to 4 years' time, leaving nothing behind. So that's why they call it disappearing stents. You put in the stent, the disease is you've rectified the disease, and the stent also goes from the body in say 3 to 4 years' time, leaving the vessel as good as normal vessel.
Doctor, what is the importance of imaging in assessing and treating CVDs, and what are the newer technological advancements in imaging CVDs?
You see, imaging one can divide in two parts. One is imaging for screening purposes. That comes an echocardiography to make an assessment of the heart function, that how the heart is functioning. Second imaging is you do a CT scan, CT angiography. That also comes in imaging to diagnose the problem. And the second type of imaging is that you do a procedure. When you say angioplasty, you imaging inside the artery to improve on the results. So there are two types of imaging that we do commonly use. One is called as intravascular ultrasound, and second we call it OCT, that is optical coherence tomography. These two imaging technologies have come up in a big way now, because we know that if we are guiding our angioplasty treatment with these modalities, the results are much better and the long-term outcome is better. I would say the recurrences are much less.
Okay. Dr. Agarwal, what do you mean by complex lesions? Because we have heard this term quite often with relation to heart attacks and cardiovascular diseases. And what are the types of coronary artery lesions, and how are these complex lesions treated?
You see, first of all, we have to understand these complex lesions are, first is a calcified lesion. All right. Second is if you are treating a bifurcation. Bifurcation means there's a big branch coming off through the lesion. So we have to treat two vessels and they are coming pretty close. So you have to do a good job on that. I'll explain later on. Third is a CTO, that's chronic total occlusions. And the fourth one, if you just see, the left mains, right? So now I tell you that in the era of bare metal stents, we were not treating these lesions because they were coming up very quickly. If you have a complex lesion and it comes back in a few months' time, you are at a loss. But once these regulating stents have come up, we are doing all these kind of lesions. Supposing we start with the calcified lesions. As we know that in India also the expectancy of the life is increasing. So more and more calcified lesions coming, they come up with age. So somebody is 65, 70. All the lesions are very, very tough. And calcium is of two types. One is a superficial calcium, one is a deep calcium. But now we have got too many devices to deal with calcium. One is called as rotational atherectomy, second one is orbital atherectomy, third one is an IVL, and fourth one is laser. All these modalities are good to treat these calciums. And this imaging modality helps you guide that which kind of modality to be used to break the calcium in these kind of lesions. So this is one subset of the complex lesion. Second subset is a bifurcation lesion again. These imaging modalities are good to treat these bifurcation lesions, where we know that how to treat with these lesions, put one stent or two stent or modify the plug before going in. So these also can be treated with a pretty, good results and long-term outcome. And third was CTO. In CTO, I think it's a major breakthrough. Initially, we were not doing CTOs, a decade or so back, but nowadays it's very frequent to do that CTO. CTO means the artery has been occluded for a long time and there's no way to treat that apart from doing a bypass. And bypass you can't do if the left system is normal. So often these people were suffering that they can't have bypass because the other arteries are normal, only one artery is occluded. But nowadays with the imaging modalities are so good, the CT scans are so good, and the equipment like the wires and the balloons are so good, we are treating all these majority of lesions are with, I would not say ease, but with less of difficulty. And the fourth one is the left main. The left main is a bigger scenario. Why? The left main controls almost 70 to 80% of the heart muscle. And if it occludes, in the older time, they used to say it's a widowmaker disease. If a left main disease is there, it's non-treated, he will not survive for a long time. But nowadays, this can be treated by both, by bypass surgery also, by angioplasty also. Because the newer stents are so good, you can put them in the left main and they are fine for ages.
Dr. Agarwal, do CVDs affect men and women differently? Because we have heard that there are times where women are more, susceptible to a disease, and men are not, and it usually happens in infants.
Disease is, I would say, not too different in both, but as the size is small, the artery size is small. So the treatment effect is much, I would say, better in males as compared to females because the size of the artery is less in ladies. That's the only difference. Otherwise, it's the same kind of problem that both of us can have.
And Dr. Agarwal, can a person post angioplasty or post PCI lead a normal life?
Certainly, that's why we do that. If we can't make him normal, I would say it has to be functionally also mobile, and like in all the aspects, he's as normal as anybody else. Like if he's treated well in time and you protect the heart functions, he's as normal as anybody else.
Dr. Agarwal, what are the hygiene factors that you would recommend after PCI is done?
You see, nothing is required because it's a closed surgery. Like nothing, no infections can catch you. Only thing is that in the post-op period, you have to be careful that while you're doing the procedure, it has to be totally, I would say, a good atmosphere. There should not be any infection inside. And all the things you are using is sterile. Otherwise, after that, once you finish the procedure and your groin is, I would say, they don't put even a stitch there. You just take out the sheath and the hole is so small, it heals off spontaneously. Nothing is required.
And what are the medical tests that you would recommend for checking CVDs?
For prevention?
Yes.
You see, in our scenario, prevention, I would say, is a very, very, I would say, difficult scene. Why? Till we have a problem, we do not approach a doctor. An old saying is that diagnosing heart attack is like diagnosing pregnancy at the time of delivery. Getting my point? It's too late. Prevention means you have to diagnose the problem well beforehand because before it can give you a heart attack. Heart attack comes after about a decade or so once you have the disease inside. It doesn't come so quickly. So we have to start investigating males if they have risk factors after 40 years of age. Ladies also if they have risk factors after 40 years of age. And if you don't have risk factors, then start your checkups at about 55 years of age, like as a routine checkup. That includes some blood tests, that includes your like lipid profile and some tests for diabetes, and then do a treadmill and echocardiogram. That's a basic test required to see if something is lying that you do not know. Right? And if they are normal, then we keep repeating them every 3 to 4 years, depending upon the risk profile and I would say extent of normality in the first set of tests.
Dr. Agarwal, we live in a world where everything is available on a 7-inch or a 14-inch screen, and people often go to the internet to look out for symptoms, to look out for tests. And there are a couple of myths that are out there on the internet. So one of the myths that I read is, do seasons play a role influencing a heart attack? For example, a winter or a summer. Can you shed some light upon it?
You see, winters are often not good for us, let me tell you. Summers are not bad. In winters, they say that a lot of spasm can happen. The blood flows thicker. There's more chance of thrombus formation. And like activities are less, eating is more. You become more sedentary. These all problems are there. But still, I would say that if we see the incidence wise, the December, January, they are bad month for us for the nights. The night calls are too many. The patients are coming in and out. And another thing happens, what happens is all the patients who have multiple heart attacks, they have less of heart function. And whenever the activity becomes less, they become more sedentary, the more chance of heart failure during the winter nights. Right, what happens is your water excretion becomes much less once the winters are around. So even if a normal water intake in a weak heart will lead to heart failure. So all these LVFs come in the nights of like winter nights, and more attacks, I would say, if you just see the change in winter and summer, certainly there are more number of attacks they come in the winters.
And Dr. Agarwal, before we wrap up this podcast, how can stress management and healthy lifestyle choices help prevent heart diseases? I mean, your piece of advice.
There's no measure to just give you advice like that, but certainly healthy habits may help, but how much nobody knows it. If somebody has risk factors, more often they are to be much more behaved than a normal person. If one knows that my family history is bad, right, and if they come with a disease and you know that there are risk factors which he could have controlled, right? I'll just give you a brief example. I've not named the person, but I've treated a person who is 36 years of age. He came in the middle of the night and he had some symptoms. So we told them that, look, it looks like angina and you need an angiogram. So he agreed for it. He did not tell anything on the very night. The next day we do an angiogram. At 36, all the three arteries are gone. One is 99%, second one is 90, third one is again 90. His ejection fraction has come down to about, say, 30%, which is normally 60%. Then I asked him that, look, you must be having some family history, otherwise you can't have the disease like that. Then he told his all chachas, all buas, all the close blood relations have got ischemic heart disease at early age of disease. And this guy has been smoking badly for last 10 years. Right? Now he comes up with it. Now I can believe that he has the disease because the family history is there and he's been smoking. And now at 36, his heart function has become half. So now we have rectified him. He's fine. But his heart function never functioned as normal. So how long we can take him up? How many years? Not the normal one, I would say. Certainly it will go a long way, but not to the normal, I would say, normal lifespan. So these kind of risk factors, if they are there, then one has to really be very, very cautious. Again, the same things are there. You have to have like healthy diet, which all of us know, but we don't believe in that, right? Eating out should be very minimal if it is required. Whenever you're eating out, you have to choose your dish. You can't have everything, right? All the tobacco and tobacco products should be, I would say, not used at all. Like they are really bad for heart disease. And a regular exercise pattern has to be there because in the offices, all the lives are sedentary. So you have to take out time, at least half an hour, 40 minutes daily to just do exercise. And recreation is very, very important. Away from work. Periodical away from work is very, very important. So that keeps you, I think, in a much better shape and healthy mentally also and physically also.
Thank you, Dr. Praveer Agarwal, for sharing your valuable insights. I hope the listeners had a great time, and so did I. So from the bottom of my heart, thank you so much for being here and for sharing your valuable time and your insights with us.
Thank you.